Acquired heart disease. Muhammad Al-Ghamdi, MD, FRCPC, PEDS, FRCPC, CARD, FAP, FACC. Assistant Professor and Consultant. Pediatric Cardiology, Cardiac Science. King Fahad Cardiac Center. King Saud University. Acquired heart disease. Rheumatic fever. Kawasaki disease. Infective endocarditis. Pericarditis. Myocarditis. Cardiomyopathy. Cardiac arrhythmias. Any case scenario of heart failure and a heart rate more than 200 is arrhythmia until proven otherwise. The commonest arrhythmia in children is SVT. Rheumatic fever. RF, most common cause of acquired heart disease in developing countries. 150 in 100,000 in developing countries, more common in developing. 1 in 100,000 in developed countries. Rheumatic heart disease, RHD, inflammatory changes to cardiac valves and myocardium. RF is the commonest acquired heart disease in developing countries while Kawasaki is the commonest in developed countries. Rheumatic fever. Precipitated by Group A streptococcal, GAS, pharyngitis, not other types of gas infections. Acquiring the disease depends on the host susceptibility, which depends on genetic, environmental, socio-economic and immunological status. 2 to 4 weeks after untreated gas pharyngitis. T-cell and B-cell lymphocytes produce antibodies against some streptococcal antigens that cross-react with antigens on myocytes or cardiac valve tissue. RF no heart sequel. Unlike RHD. RHD will lead to rheumatic fever, which will lead to well-established disease. It is not due to the infection itself, rather due to cross-reactivity between myocytes and bacterial antigens. Not from one infection but clinical plus subclinical infection leading to acute rheumatic fever, and if it is not recognized, rheumatic heart disease. Rheumatic fever Jones criteria, 1992, major manifestations. Minor manifestations. Carditis. Arthralgia. Polarthritis. Fever. Chorea. Raised ERS or CRP. Erythema marginatum. Prolonged PR interval on ECG. Subcutaneous nodules. ASO greater than 480 IU/ml. Anti-DNAs greater than 680 IU/ml. ASO titer may be normal initially. Need to repeat in WKS if high suspicion of ARF. CRP level of greater than or equal to 30 mg/L. ESR of greater than or equal to 50 m/H. ESR in ARF is typically greater than 80 mm per hour, usually remains elevated for greater than 4 weeks, and may remain elevated for 3 to 6 months despite a much shorter duration of symptoms. CRP concentration rises more rapidly than the ESR and also falls more rapidly with resolution of the attack. Evidence of antecedent gas infection. 1. Positive throat culture or rapid antigen test for gas. 2. Raised or rising streptococcal antibody titer. Rheumatic fever Jones criteria, 1992. 2 majors or 1 major and 2 minors plus evidence of antecedent gas infection. ASO titer may be VA, repeat in 2 to 4 weeks if there is a high index of suspicion. Exceptions. Chorea and indolent carditis do not require evidence of antecedent gas infection. Recurrent episode requires only 1 major or several minor manifestations, plus evidence gas infection, rheumatic fever, arthritis. Most common ARF presentation, 75% of first attacks. Migratory, asymmetrical, polarthritis, of large joints. Typically, extremely painful. Highly responsive to salicylate and NSAID therapy. within 3 days. Monoarthritis if history of early use of NSAID. Premature abortion nipple arthritis manifestation. You can't give aspirin if patient has already started on NSAID. Swelling of the joint. 2 or more of the following. Limitation of movement. Hotness of the joint. Pain and or tenderness, typically, extremely painful. Rheumatic fever carditis, valvulitis. Isolated MV is the commonest, followed by MV plus avenue then avenue, and rarely affects the right side. Early disease leads to valvular regurgitation. Prolonged or recurrent attacks lead stenosis. Pericarditis and myocarditis may occur. RHD is less rare in children less than 5 years because it requires recurrent infection. Congestive heart failure in ARF results from valvular dysfunction secondary to valvulitis and is not due to primary myocarditis. The rheumatic etiology can usually be confirmed by a typical appearance on echocardiography. In New Zealand, echocardiographic evidence of subclinical carditis can also be accepted as a major manifestation. Rheumatic fever synonyms: chorea, jerky, uncoordinated movements especially of hands, feet, tongue and face. Disappear during sleep. More common in adolescence female. Occur after a prolonged latent period following gas. 6 weeks to 3 years following gas infection. Strong association with carditis. In synonym chorea, it's RHD until proven otherwise. Because it can happen 3 years post-gas where it's hard to find any evidence of strep infection. Therefore, anyone with chorea should do echo. Usually seen in people who have beautiful handwriting and suddenly drops. Rheumatic fever erythema marginatum. Rare and difficult to detect especially in dark-skinned patients. Circular patterns of bright pink macules or papules that blanch under pressure. Trunk and proximal extremities. Almost never on face. Not itchy or painful versus eczema. Rheumatic fever subcutaneous nodules rare, less than 2% of cases. Highly specific manifestation of ARF, but it is not sensitive. Round, firm, mobile and painless nodules. Appear 1 to 2 weeks after onset of other symptoms. Last 1 to 2 weeks, rarely greater than 1 month. Strongly associated with carditis. Rheumatic fever treatment. Antibiotics to eradicate of residual gas bacteria. Anti-inflammatory agents. High-dose aspirin or NSAIDs. Steroids for severe carditis. CHF therapy as indicated. Primary prevention by preventing the infection from happening, secondary prevention to prevent repeated infection. Because RHD doesn't occur from the first attack, it needs several episodes to occur. Synonym chorea. Haloperidol. Secondary prophylaxis. Rheumatic fever secondary prophylaxis. Secondary prophylaxis. Antibiotic. Dose. Route. Frequency. First line. Benzathine penicillin G. BPG. 1,200,000 U greater than or equal to 20 kg. 600,000 U less than 20 kg. IM. Q4WKS or Q3WKS if confirmed. Recurrent ARF despite adherence to 4 weeks injection. Second line. Penicillin V. 250 mg. Oral. BID. Penicillin allergy 0.2% only. Stop penicillin if patient has anaphylactic shock. Erythromycin. 40 mg/kg/day, children. Bidkid. 400 mg, adults. First dose of secondary prophylaxis should be delivered in hospital. Second line, phenoxymethylpenicillin, penicillin V, if IM route is not possible or refused. BID regimens are also likely to result in poorer rates of adherence over long periods of time and less predictable serum penicillin concentrations, when compared to intramuscular BPG. Recent Cochrane meta-analysis. Use of penicillin, compared to no therapy, is beneficial in the prevention of recurrent ARF. Benzathine penicillin G, BPG, is superior to oral penicillin in the reduction of both recurrent ARF, 87 to 96% reduction, and streptococcal pharyngitis, 71 to 91% reduction, level I. Secondary prophylaxis also reduces the severity of RHD. It is associated with regression of heart disease in approximately 50 to 70% of those with adequate adherence over a decade, level 3-2, and reduces mortality, level 3-2. While BPG is usually administered every 4 weeks, 28 days. Serum penicillin levels may be low or undetectable 28 days following a dose of 1,200,000 U. Fewer streptococcal infections and ARF recurrences occurred among those receiving 3-weekly BPG, level I. 3-weekly regimen resulted in greater resolution of mitral regurgitation in a long-term randomized study in Taiwan, 66% versus 46%. Prospective data from New Zealand, however, showed that recurrences were rare among people who were fully adherent to a 4-weekly BPG regimen. 4-weekly regime is preferable to a 3-weekly regime because of the resource and compliance implications, grade D. In New Zealand, 3-weekly, 21-day, BPG is recommended only for those who have confirmed recurrent ARF despite full adherence to 4-weekly, 28-day, BPG delivery. An alternative strategy is the administration of larger doses of BPG, leading to a higher proportion of people with detectable serum penicillin levels 4 weeks after injection. However, until more data are available, this strategy cannot be recommended. The rates of allergic and anaphylactic reactions to monthly BPG are 3.2% and 0.2%. When patients state they are allergic to penicillin or when a nonspecific reaction has been reported, they should be investigated for penicillin allergy, preferably in consultation with an allergist. BPG injections in conjunction with anticoagulation therapy. Injections should be continued for those who are anticoagulated, unless there is evidence of uncontrolled bleeding or INR is outside the defined therapeutic window. The fact that penicillin has failed to eradicate this disease process is irrefutable proof of the need for more laboratory, epidemiological, and clinical research. In another word, some experts suggested it is not because penicillin is not working but because either lack of penicillin or problem with underdiagnosis. Kaplan L. Hart. 2005 Gen. 91 1, 3-4. Duration of secondary prophylaxis. Rheumatic fever. Duration of secondary prophylaxis. Category. Duration of prophylaxis. ARF with no or mild carditis. Minimum of 10 years after most recent episode ARF or until age 21 years, whichever is longer. ARF with moderate carditis. Minimum of 10 years after most recent episode ARF or until age 30 years, whichever is longer. With ARF with severe carditis. Minimum of 10 years after most recent episode ARF or until age 30 years, whichever is longer. May need lifelong prophylaxis. Individuals working or living with children or in a living situation where there is overcrowding or close proximity to others, such as boarding schools, barracks, and hostels, have a higher risk of exposure to gas and subsequent development of ARF. In these cases, consideration should be given to extending the duration of prophylaxis. For those presenting at an older age, over the age of 21 years, with no or mild carditis, It is possible to consider discharge from prophylaxis after 5 years. Damage to the heart is permanent, whereas the arthritis. Kawasaki disease. KD, inflammatory disease of unknown etiology causing acute, diffuse vasculitis of medium-sized blood vessels, mainly coronary arteries. Most common cause of acquired heart diseases in developed countries. More common in Japanese population. Higher in males than females. Typical age, 6 months, 5 years. Kawasaki disease cardiac involvement, other medium-size arteries. Coronary arteries late, if left untreated the risk of CAD is 25%, this is reduced to 2% with treatment. Dilation and aneurysm formation. Thrombus formation. Fibrosis and stenosis. Myocardial infarction. May cause myocarditis and endocarditis. Other medium-size arteries. Axillary, femoral, iliac, and renal arteries. Kawasaki disease fever, at least 5 days duration. At least 4 of the following, to call it complete typical KD. Conjunctivitis, bilateral, non-purulent. Skin rash, polymorphous skin rash. Mucous membrane changes, red, dry, and cracked lips, strawberry tongue. Extremities changes, palms/soles erythema, hands/feet edema, skin peeling. Cervical lymphadenopathy, unilateral and greater than 1.5 cm in diameter. Kawasaki disease DDXOKD, scarlet fever EBV infection. Adenovirus infection. Staphylococcal scalded skin syndrome. Drug reactions. Stevens-Johnson syndrome. Kawasaki disease atypical, incomplete, KD. Cases of KD that do not fulfill diagnostic criteria. More common in infants. Children with fever greater than 5 days. 2 or 3 classic symptoms. Supporting laboratory abnormalities or echo evidence of coronary involvements. Should be treated as KD. Kawasaki disease labs abnormalities in KD, elevated ESR greater than 50, 70%. Elevated C-reactive protein, 50%. CBC. Neutropenia, leukocytosis, 50%. Nonspecific anemia. Thrombocytosis more than 500,000 is very pathognomonic. Marker of KD. Not seen until second week of the disease. Elevated liver transaminases, 40%. Low serum albumin level. Sterile puria, 33%. Aseptic meningitis, up to 50%. Kawasaki disease treatments, IVIG 2 grams/kg. Second dose if persistent fever within 48 hours of the initial dose. High dose of aspirin of 30 to 100 mg/kg/day. Once a febrile, aspirin is decreased to 3 to 5 mg/kg/day. Aspirin acts as an anti-inflammatory agent if given high doses for long time, analgesic if given in medium doses when needed, and antiplatelet if given in small doses for long time. Echo at baseline. Repeat echocardiogram and inflammatory markers at 6 to 8 weeks. If normal coronary arteries and inflammatory markers, aspirin can be stopped. If coronary artery abnormalities, long-term RX with aspirin. Other anticoagulants warfarin if giant aneurysm of coronary arteries. Infective endocarditis. Infection of the endocardial lining of the heart or cardiac vessels. Rare but with high mortality. Usually affect abnormal cardiac structure. Valvular disease. Septal defects. Presence of foreign material such as mechanical valves and patch material after surgical repair. Infective endocarditis. Etiology. Gram-positive bacteria. Greater than 90% 0F bacterial case. Streptococci viridans, most common infectious agent. Staphylococcal species, especially prosthetic valves. Enterococci, less common pediatric age group. Gram-negative bacteria. Less than 10% of bacterial cases. Example, Hossack group. Haemophilus, Actinobacillus, Cardiobacterium, Eikenella, and Kingella. Fungal, uncommon. Neonate, immunocompromised patients, prolonged antibiotic. 10% E-case, organisms cannot be identified. Infective endocarditis. Clinical features. General. Fever. Nonspecific manifestations. Myalgias, arthralgias, headache, and general malaise. Cardiac. New onset or worsening valvular regurgitation. Congestive heart failure. Heart block. Infective endocarditis. Clinical features. Extracardiac, septic embolism, ischemic changes can occur anywhere even in the brain causing stroke. CNS, infraction, brain abscess. Renal, proteinuria, hematuria, puria. PHX, stigmata of SPE. Janeway lesions non-tender, flat lesions on palms and soles. Osler's nodes, tender, raised nodules on fingers and toes. Roth spots, exudative lesions of the retina. Splinter hemorrhages, non-blanching, linear, under nails. Splenomegaly, infective endocarditis. Labs. Blood cultures are the most important lab test. 3 blood cultures collected over a 24-hour period from different sites at different times. Because if only one of the cultures is positive, it could be contamination. CBC. Anemia. Elevated ESR/CRP. Positive rheumatoid factor, infective endocarditis. Treatment. Supportive medical therapy. Prolonged antibiotic therapy. Initially empiric broad-spectrum IBGS which then adjusted according to organism sensitivity. Admit for I.V/IBGS with a combination of 2 or 3 drugs. 4 to 8 weeks course depending on the type of organism and resistance. Removal of infected line. Surgical intervention may be required. Infective endocarditis. SBE prophylaxis. Only indicated at dental procedures or respiratory procedure, not for gynecological procedures anymore, for high-risk patients. No longer recommended for GI or GU procedures. Prophylaxis regimens. Or lamoxicillin 50 mg/kg, up to 2 grams, or 4/M-ampicillin 50 mg/kg. Patients allergic to penicillin. Cephalexin 50 mg/kg PO, up to 2 grams, or clindamycin 20 mg/kg, up to 600 mg, or azithromycin, or clarithromycin 15 mg/kg, up to 500 mg. Infective endocarditis. SBE prophylaxis. Prosthetic cardiac valve. Previous E. Congenital heart disease. Unrepaired cyanotic CHD, including those with palliative shunts and conduits. Repaired CHD with prosthetic material or device, surgery or cath, during the first 6 months after the procedure. Repaired CHD with residual defects at the site or adjacent to the site of a prosthetic patch or prosthetic device. Cardiac transplantation recipients with cardiac valvulopathy. Myocarditis. Inflammatory infiltrate of the myocardium with necrosis/degeneration of the myocytes. Viral infections, most common causes in order: Coxsackie type B, adenovirus, parvovirus B19. Others: CMV, EBV, HIV, Hep C. Other infectious causes: bacteria, Rickettsia, protozoa. Non-infectious causes: rheumatologic disease, SLE, rheumatoid arthritis. Drugs and toxins, chemotherapy. Myocarditis variable initial presentation. Viral prodrome, fever, urti or GI symptoms precede the SS of HF by 3 weeks. HX, lethargy, poor feeding, irritability, respiratory distress, exercise intolerance. PHX. Signs of CHF: tachycardia, tachypnea, increased work of breathing, gallop rhythm and murmur of mitral regurgitation. Hepatomegaly. Myocarditis investigation, CXR, ECG, echo, cardiomegaly. Pulmonary congestion. ECG. Sinus tachycardia. Low voltage QRS. Nonspecific T-wave changes. Echo. Dilated LV with reduced systolic function. Mr. Pericardial effusion. Myocarditis investigation, treatment, myocardial biopsy. Historically used to be the gold standard test. Currently not routinely performed. Invasive. Low sensitivity of the procedure, 3 to 63%. Patchy involvement of the myocardium. Treatment. Cardiorespiratory support. Inotropes, ventilation, ECMO. Anti-CHF therapy. IVIG and steroid, not supporting evidence for their benefit. Antiviral agents and interferon, need further studies.